If you can get bursitis, arthritis, or osteomyelitis with this affected bone, this pattern gonna have has high risk of morbidity because it can cause structural damage and is life-threatening sometimes. So we consider that it's a quite aggressive pattern, and this is the most aggressive infections that can cause is life-threatening. We once called it necrotizing fasciitis, but right now we think it's even affected more than fascia. So we try to call it is necrotizing deep soft tissue infection. So look at this leg. She is a lady that had high pain for 3 days and extensive limb swelling. And when you look closely to the skin, you can see black and skin necrosis. So this means that vascularity that goes to the skin surface has been cut by the infection. So this can lead to very aggressive pattern and life-threatening. And look at this one, but you can express it by MRI. On the images, you can see the thickened soft tissue, thickened fascia between the muscles and this hypertense fascia. On gadolinium study, you can see area that has variable of enhancement, but when it has non-enhancing fascia, we have quite have confidence to make the diagnosis of necrotizing fasciitis. And anyway, this pattern may not be specific, but if it's obvious, what does obvious mean? If you found gas with this low signal intensity on T2 weighted images, it is rarely seen, but it's specific pattern. Or if you have thickened enough, that means like a T2 hyperintense area that's thickened enough, and thickened enough means more than 3 millimeters. That means it's accumulation of fluid that's thick enough. And anyway, if it's involve more than one compartment or multiple compartments, 2 or 3 compartments, this means the disease is extensive enough to tell that this necrotizing fasciitis. Another thing that will show you the example of infection in deep soft tissue when you have acute osteomyelitis. The lady she has leukemia and also have acute febrile illness. So leukemia itself can cause fever. Leukemia itself can cause bone destruction around this area. But how can we differentiate between leukemia and the infection of the bone? We do this, we do MRI. We can see on T1 weighted images, we can see it's bright signal on T2 weighted images that this tissue has edema or fluid. We can see bright signal on T1 with considering drop on fat suppression images. So this is fat growth. And when we stick the needle in and draw the pus, we can see this is pus and also the fat growth. The lady has some localized septicemia, and pus actually means, fat growth in the pus means you have increased intramedullary pressure that lead to lymphocyte cell death. If this means the pressure inside the bone increased rapidly. This is the very aggressive pattern. Actually, it's not specific for infection, but the diseases that can cause that damage mostly are infectious conditions, and can represent other, but very rare, is bone marrow necrosis related to chemotherapy or radiation therapy, and something like Gaucher disease or Paget disease. We have very few cases has been reported, but most of the time is reflect osteomyelitis. Okay, another example to show you the patterns of infectious disease. This is a chronic osteomyelitis. This guy has leg pain in the past 1 month and severe pain for the past 2 years. Radiographs show this area. Actually, for radiologists, you can tell that if you have shell like this, that's scortic bone, that's a repetitive bone. Why the patient has pain within these last 2 weeks? That's because we can show it on MRI. We can see the area that's bone has been destroyed. The area that is bright signal on T2 weighted images, this means edema and something inside this. You can see it has, when we get gadolinium, you can see the abscess. And you can see something outside the bone. That means that the disease, you have this area which is called cloaca. So there's a defect in the bones, that the infectious disease inside the bone come out to soft tissue. That's why the patient get a symptom with pain recently. So this is why infectious disease in musculoskeletal is quite a challenge in making diagnosis. Okay, so let's look at role of MRI in infectious disease. That we can use this in diagnosis. We can use this in determining disease extension, which is very helpful in clinical practice and is help guiding your treatment. So, this one, if you see this patient, time mass for 2 years, who will think this is an infectious disease? No, we think this is soft tissue mass. But when we do MRI, this is coronal MRI images, third images. This is cystic consequences. You can see cystic mass with something called rice body. Rice body is like it's a low signal intensity on T2 weighted images that has look like grain of rice. And this in our region is reflected as chronic disease, mostly are tuberculosis, and this area we call it tuberculosis bursitis. So this is how the rice body look. So you can see the grain of rice on a sac of fluid. And this is rice body, and this is a microscopic view of rice body, which actually is comprised of collagen fiber and mononuclear cellular this area. It's not very specific for infection, but it's reflect that chronic disease, like rheumatoid arthritis also have this. Seronegative spondyloarthropathy can present this one as well. But most of the time in our region is with a chronic infection, mostly a granulomatous infection. Okay, another one, we can show the utility of MRI in looking at disease extension. The guy has fever and painful and swelling elbow. So the doctor requests to look for MRI to see the extension of disease. Why? Because for surgeon, they have to go in and drain the pus. But where to put the needle in, where to make the open surgery, so we do MRI. Okay, look at this arm. So this area definitely is redness and swollen, right? So this area also swelling of the forearm. This area looks normal. Okay, for MRI, you can see this area, this is a T1 root gap. So with rim enhancement, it represents access around this area. Actually, what below here is the dependent portion that has less motion. So the patient has swollen, the simple swollen, because it's a dependent part, but this area is access. But how about this area? It's also enhanced, it's also swollen. This is an osteomyelitis deep in the bone that you cannot, is unnoticeable on outside. So this is the utility of MRI to show you the extent of disease, that the doctor can go in this way, and they also have to go in this way to do the surgery as well. So the point is, first of all, to image like this, you have to be aware that you have to cover all these areas in the study. You cannot just only concern to this area, but be flexible when you do the scan of patient, that you can repositioning of the patient in the during the scan to cover the whole thing. It's important to get point selection to make the adequate to cover the adequate area, adjust FOV during the scan. And for technologists, it's very important to look at the patients and detect the lesion while you do scanning. Right? Okay. So another thing is when we images the area that the patient cannot do the normal positioning, well positioning, like when elbow flex, when you have to extend the image in the glass field view, you will get the problem with susceptibility artifacts. And for us, for musculoskeletal radiologists, it's very important to get the suppression with gadolinium to see the abscess. Wow. So fast suppression is very important, and we can do, and I believe you have a couple of things to do with better fast suppression, but some simple thing is right. It has been done by the group from Japan, and actually rice hand is, okay, what we use in my practice, we use elbow stocking, put the rice within this, and then make some fat, and then put it around the area that we want to shape it in the nice view, so we can get homogeneity during fast suppression. So this is a simple technique that we use. And you can apply also hands and the other area of body as well. So it's very helpful. Okay, all right. So another thing that we have to be concerned that one mechanism of infectious disease is hematogenous spreading. So it's very important to get all the disease burden in your body. This guy has septicemia. Septicemia means you have infections of, you have hemoculture positive. This means infectious disease spread around in your blood. He already has shoulder arthritis, and he also has low back pain. So we do MRI on T2 weighted images. We can see the information around this area is edema here. This area. When we do T1 with gap, we can see it's enhanced, definitely confirm the infectious disease around here. Because can also see that the infection come out to epidural soft tissue. It can cause pain because it's entrapped nerve roots, but it may not enough to look at only this area, because this is the inflammatory process in that first one that we can detect. But you can have all together the other area that have infection as well. So multiple level in lumbar spine is not a big surprise. Why? Okay, and then the patients also have infectious disease in the thoracic spine. So based on this, okay, another thing, the patients also have pyomyositis in this area, in his back as well. So the pain can be the source from this one and all together with several levels of spinal infection. So this is the data that we found from the study. This has been done for a while. That hematogenous spread can cause multiple sites, and for spondylolisthesis, 10 to 15%, the patient can present with multiple levels. So this means when we get concerned about spinal infection, it's better to image the whole spine to see the disease burden. And sometimes people talking about the whole body scanning to see the entire body burden of the disease. Anyway, the spinal and pelvic bones are the main area of interest because those are areas that has been well vascularized in your body. Okay, so when you found infective spondylitis, particularly in patients who have septicemia, it's better to screen the whole spine. And in my practice, I will do STIR or T2 with fast suppression to screen the whole thing. Another thing in our practice is how to differentiate, how to distinguish between infection and non-infectious disease. Okay, and this is an example. The lady has diabetes mellitus. She has foot swelling, warm bladder. Certainly, people will think this is clinically like infectious disease. And when we do T1 weighted images, we can see the abnormality here. This is bone marrow replacement. bone marrow is supposed to be white like this, but it's dark like this on images. When we do T2, it's confirmed that there's something changed in the bone this area. When we use contrast study, it's enhanced. Okay, perfectly with osteomyelitis. But anyway, bone marrow edema can occur in anything. And in this case, the patient can be treated with non-weight bearing for 6 weeks without antibiotics. And the disease, the patient feeling better and the image gradually seems to be better after we do follow-up study. So she has been diagnosed as early stage of neuropathic joint disease. So this area, actually the arch of foot, that is weight-bearing area. So with this one, I would say bone marrow replacement is not specific and it sometimes can mimic. The underlying disease can cause the other disease that mimics infectious disease. And the real osteomyelitis in diabetic patients usually, virtually, always, almost every time related to soft tissue infection or ulcer. Whenever you see ulcer, it extends to bones. Okay, so this area is the actual image of your foot. This area is the soft tissue that has been infected. And it's white bright on T2 weather images is enhanced in post-contrast study. This area considering ulcer, and the ulcer extends to bones. So this is an osteomyelitis related to that big foot. So it's very important to look at clinical and clinically of the patient so you can nail the diagnosis. And because the ulcer gonna be at the area of bone prominence, so it's usually have regions that predisposing to infection because it will occur at metatarsal head, calcaneum, malleolus, and toes. It's not pediation in the arch of foot where the midfoot, where the weight usually goes there. So the location also helps you to put together everything to make the diagnosis. Okay, all right. Okay, this one. Infection or non-infection, this is our question. The patient has pain for 8 months. 8 months, it's just a long time. And on T1 weighted images with contrast enhancement, we can see this enhancement. And actually, when we look at everything, T1 weighted images, T2 weighted images, it's like maybe the patient may have rice body around here and enhancement. So definitely, we made the initial diagnosis as the tuberculous bursitis. But after we treat patients for a while and follow up patients for a while, it turned out that the patient had another shoulder pains and also wrist pain. So final diagnosis finally turned out to be rheumatoid arthritis, and the clinically fit with rheumatoid arthritis. So in general, for doctors, you may know that monoarthritis tend to be infection. But sometimes rheumatoid arthritis can present with monoarticular disease in the initial state of disease. And 50% of infection came with multiple joint disease because it's hematogenic spread. So please be aware of this, and this is the challenge in clinical practice. Okay. So inflammation is not specific. It can be infectious or non-infectious condition. Okay, so do we have the signs in MRI to distinguish between infectious or non-infectious disease? Actually, these are non-infectious process. Okay, all right. And another thing is para-articular abscess. If you find para-articular abscess in the soft tissue, it's direct due to infectious process as well. But anyway, infectious process never is looks. So this one is the patient has proven septic arthritis based on joint effusion as well as hemoculture. The patient do not have effusion at all, but he has synovitis and inflammation around the joint. So this is another pattern of septic arthritis as well. Another thing is you can see bright signal on T2 weighted images, enhancement in the post-contrast study, definitely everybody will call it abscess, right? But, okay, look more closely, abscess, definitely. Any radiologist will call it abscess. We do stick the needle in, and what we get is a chalk white fluid. It's not like abscess that we see. We put this on microscopy. So this one is polymerized light microscopy. That's anything along this axis. If it's yellow, it will represent uric crystal. So this is inflammatory process related to uric crystal. So inflammation from the other things, not just only infection, by uric crystal also present this as well. Okay, another thing that may look like infection, but you should be aware of. So the lady has leg pain, and certainly she has a lot of pockets that look like abscess, right? Because you have bright signal on T1, on T2 wet images, and you have enhanced area with multiple rings and hanging. When you look closely, you can see actually there's an area that's very thin wall that looks like abscess, and another area that looks like bulgy of mass. When we look at her history, she has cervical uterine cervical cancer, which is mostly a squamous cell carcinoma. And when you look closely at this area and comparing this with pathological findings, this area is a viable squamous cell carcinoma. Another area, this area is necrosis. So it looks like the slump of your skin. There's forming a mass, and this looks like abscess. So this is another area that infectious disease can mix up with non-infectious process. So the bottom line is, please be aware of infectious disease that may, the other things like tumor and crystal deposition disease that may look like infectious as well. So when you look closely to see the viable tissue that has cell and this area is blocked off the epithelium. So this is a metastasis carcinoma. So to sum up with the joint disease, that you have variable imaging patterns, intraosseous abscess gonna guide you to be concerned about infectious process. But sometimes even these synovitis, just only the synovitis, direct you to infectious disease as well. And please be aware of crystal deposition disease that may look like infectious process. And when you look, just only the lesion of infection is not enough. And MRI is very helpful to look at this. This one, you can see is definitely is bursitis with rice body. So we have learned that the patients will have infectious process and chronic infection. And this one is the T1 with gap. Definitely is infection. But you can see something dark, this area, which represents fluoroid. Actually, the patient, we do CT scan, we can see dilated vessel, blood vessel, and actually this patient has some normal variation which is called persistent sided vessel. So the vessels run in this area, which usually not the normal area that the vessel will be. We will not have vessel in this area because she has infectious process around this area. So that's why the inflammation caused what we call is pseudoaneurysm. So dilated of vessel in this area. And we can show it by doing ultrasound, and this is a full, is in the dilated vessel. So when get infectious process, not just be satisfied with your report, just look furthermore whether the patient has complications related to this disease as well. Okay, one thing that MRI can help, and is also the questions that people who working in technical field may help be dealing with this problem is the disease monitoring. Okay, this guy has pain for 2 weeks and culture grew septic galaxia. So this is initial joint disease. Okay, for those who are non-radiologists, is considering joint space narrowing because it's loss of cartilage. And this can be shown by MRI, as the patient has bone marrow edema and narrowing joint disease, narrowing joint and synovitis. In 6 months, even the patient feel better, no signs of infection at all. The joint space narrowing keep going. That's because he has complicated osteoarthritis. And with 1 year after follow-up study, the change in bones and in both in fluid-sensitive sequence and enhancement still persists, even no sign of infection at all. So this is a challenge point in our practices, being concerned that after the infection, even infection subsides, you get the other disease, which means osteoarthritis, and it can make it persistence of the change. At this process, in my practice, I look at access and I look at the follow-up study. If it keep going down, there will be signs of improvement of disease. But anyway, in general, we don't have definite signs to say it's the end point of the treatment. Okay, one challenge is host immunity because infectious process.